Dr. Vicki Sharp, thanks so much for joining us. It's nice to see you again. I had the pleasure of working with you on the HealthRight board for many years, and now you're joining our emeritus board, which is super exciting. And we're really thrilled that you're taking some time to talk with us as we celebrate 30 years of HealthRight. You've been part of HealthRight, involved with HealthRight for the majority of those 30 years, and so we thought hearing from you would be a wonderful opportunity to get some perspective, both on HealthRight's history and origin story, and also your thoughts on the continued relevance of our mission today. So welcome, and thanks again for speaking with us.
Thank you, Peter. And it's really an honor to be asked to serve on the emeritus board. And I look forward to our conversation today.
Yep, likewise. So why don't we start at the beginning? HealthRight, when I joined HealthRight, I was really struck by the origin story. And I recall one of our very early conversations when I was interviewing for the position about HealthRight's origin story. It's really compelling. There's a lot of detail to it, but maybe you could just give us a quick overview of that story and why Jonathan and you and some of your colleagues started HealthRight back in 1990.
Well, Jonathan, as you know, was a physician and had worked in public health and AIDS, and was the first to articulate the need for public health and human rights to be connected. Up until Jonathan, those were two very separate worlds. They had a separate literature, they had separate meetings, and Jonathan said, we really need to connect public health and human rights. And that he articulated the rationale for that was that where you have violations of human rights, you have an impact on health. And so it was at about the time that he articulated that, so it was early 1990, that he, along with someone from Médecins du Monde, the parent organization in France, Dr. Patrick Eberhard, as well as Aryeh Nair. And Aryeh was the co-founder of Human Rights Watch, and then at that time was the president of the Open Society organization, institute. So Jonathan and Patrick and Aryeh thought that it was time for an organization in the United States to sort of connect these public health and human rights issues. And that's how it got started. And Jonathan was an early member of our board. Aryeh was sort of in the background, but frankly, through many years, Open Society was a substantial part of our funding. And every year I would meet with Aryeh and go over what we had done in the year, and he would fund us for yet another year. So Jonathan, I think, was the one that had that vision, but Aryeh was there with critical funding that without we would not have survived.
And so give us a little bit of insight into some of the events that led to this inspiration, this insight that Jonathan and a few others had that human rights had an intrinsic role, a critical role to play in the achievement of better health, particularly for marginalized communities. And specifically, I'm thinking of the story around Haitian refugees who were detained in Guantanamo Bay. I think that was really, as I understood it from you, one of the critical events that really sort of led to connecting these dots, as you say, and to establishing Doctors of the World USA, which was HealthRight's previous name.
Right.
The organization rebranded in 2007. So maybe you could tell us briefly that story about the Haitian refugees, which weaves together issues of obviously human rights and health in it's sort of a really crystal clear way that I think people will really understand and will resonate with.
Well, my introduction to Doctors of the World was, professionally, I was an AIDS physician who actually had visited Haiti as a tourist on many occasions and was really liked very much the country and had an affection for Haiti. And I was reading about HIV infected Haitians who were essentially incarcerated on Guantanamo, and sort of said, you know, you should get involved. And New York being New York, took all of 2 phone calls. I connected with Doug Shenson at Doctors of the World, and literally 2 weeks later, I was on a little single engine plane going from Fort Lauderdale to Guantanamo on something called Air Sunshine, which I think was some kind of CIA front, but that's a whole nother story. We went down to Guantanamo, and I was there the first trip for 2 weeks, and we interviewed the Haitians who, and just to back up for a minute, people remember there was a coup in Haiti. Haitians fled in these very rickety boats. They were picked up at sea by the US Coast Guard and brought to Guantanamo. On Guantanamo, they were interviewed by the INS. And the standard is, the standard is credible fear of persecution should you be returned home. Those that didn't make that standard were returned home. Those that did were brought into the United States to apply for asylum, except for one group. And that was before people were allowed to leave Guantanamo, they were tested for HIV against their knowledge or their consent, but they were tested, and there were about 300 Haitians who tested positive, and they were removed to a remote part of the military camp at Guantanamo. And they were there for something like 18 months. So they were there during the Bush-Clinton presidential campaign when this became a topic, and Clinton said when he was elected, he would take care of the camp. And in fact, after he was elected, nothing was done. And I came back with a T-shirt that one of the Haitian individuals who was incarcerated in this HIV camp had written, "Mr. Clinton, don't forget, promise you made of us." And it said, we doing nice math for you. And that was a direct translation, I think, from the Creole to the English, because in French you would say, "On a compté sur vous," we were counting on you. So these Haitians languished in this camp for better than 18 months, and some died. There was a woman who became pregnant, and they did not consider HIV a high-risk pregnancy, and she delivered and the baby died. Subsequently, a good way to get out of that camp was to get pregnant, because the US government and military recognized that that was a high-risk pregnancy. In any case,
and babies dying or bad in custody are bad luck.
It's bad luck, bad PR. So we came back, and Doctors of the World worked with a coalition of attorneys, the Yale Student Law Clinic and Lawyers Committee for Human Rights, and brought a case in federal court. And it was a very powerful moment, because we realized that our testimony as physicians was very compelling, and that when we spoke about the conditions of HIV-infected Haitians in this camp, the court was convinced, and the Sterling Johnson, who was the judge, said this is a public health disgrace, and he ordered the camp closed. So by that time, there were about, I think, 185 Haitians who came into the country, primarily to Miami and to New York, and were able to pursue asylum applications. Remember, they had all met the standard of credible fear of persecution if they were returned home.
Right.
So that was an extraordinary moment for us at Doctors of the World, where we were able to have a direct impact on the lives of these incarcerated Haitians.
Yeah, I love that story, and just because, again, in such a clear way, it brings together. It just showcases the ways in which human rights and health are intertwined, and that by in detaining these Haitian refugees who are fleeing persecution and happen to be living with HIV, not providing adequate care, that the sort of the rights violation exacerbated the public health crisis. And,
Absolutely, absolutely.
and so I think it's such a great story. I always love hearing about it. And I think, I just totally lost my follow-up question. I had another question
I will tell you an anecdote. In those early days, when Jonathan was on our board, we did board retreats. And Jonathan was a great storyteller. And he also, one of the things he said was that when you go on retreat, it's very important that you have an overnight, because the things that you discuss on your initial day, they need to sort of percolate while you sleep, and that you get up the next morning and sort of take a fresh look at whatever ideas that you're talking about.
Yeah, for sure. One of the things that I wanted to mention was that another interesting part of that story with Haitian refugees is that it really laid the foundation for a piece of work, for a program within HealthRight that continues to this day, which is our human rights clinic, which is focused on addressing the needs of asylum seekers who are survivors of torture and other types of human rights violations, who are seeking safe harbor here in the United States, and that work continues today. And so it's also a wonderful sort of consequence of that story is that it has inspired the work. It's work that we've worked really hard over the years to maintain and continues to this day. Which leads me to
the more compelling today, given what is going on in the United States.
Sadly, it is as relevant today, right. Yes, as it was in the late 80s and early 90s. Which brings me to the next question, Vicki. I'd love to hear you reflect on HealthRight's history and the ways in which HealthRight has evolved and changed as an organization. As I said, as we've established, you're involved from the very beginning. Here we are 30 years later. I'd love to just hear you sort of reflect on the ways in which the organization has changed and evolved in your view.
Sure. I think initially we followed very much the model of our parent in France and focused on a lot of our activity on emergency relief. And over time, we, when I say we, I mean Doctors of the World USA, I think listened to and read more about Jonathan's work and how we wanted to, the direction that we wanted to take. And it was away from emergency relief. It was dealing with situations where violations of human rights have an impact on health. But in addition, we wanted to create longevity. We wanted to be able to say we were there and we worked with local populations and we left something behind. And sustainability, I think, is the word that we use. So that is the direction that I see. I don't know about you, Peter, but that was the direction that we took, looking at where we got involved. The decision about where we got involved was not necessarily where there's some emergency in the world. Frankly, we thought that there were organizations that were better suited to respond to emergencies. We really wanted to work where violations of human rights had an impact on health. And again, following Jonathan's example, we developed a human rights approach. It wasn't just theoretical, but sort of developed the metrics that said, you know, are we having an impact not only on health, but on human rights?
Right. Yeah, I think that the major way in which that plays out is our focus on marginalized communities, these communities that are, for one reason or another, dislocated from their health systems, and their fundamental right of access to health is being violated, typically by virtue of who they are or where they are. And I think the other thing, if I'm hearing you correctly, I think the other impetus was the recognition that after a humanitarian crisis, the after effects, the sequelae of that crisis continue. They linger for many years. And these communities, even once this sort of acute phase of the crisis has passed, that there is a continued need to address the health issues of these communities, who, by virtue of the fact that they've sort of survived a humanitarian crisis, remain somewhat dislocated. And I think there is a little bit of there's one of the things in global health and development that we've not quite gotten right. And I think that this was sort of present as the organization shifted from a focus on sort of service delivery and humanitarian response to what we do now, which is strengthening health systems, building up health systems, building the capacity of these systems to deliver healthcare to these communities over the long term. Was this recognition that there's a little bit of a disconnect between the moment where the humanitarian response ends and capacity building, the health system strengthening, the return to quote unquote normalcy begins.
Right. Right.
That makes sense. Yeah.
I think also, I remember one of the first trip I took to Kenya, when we were we recognized, there were a group of us that were HIV docs who were on the board, and we said, here we are, HIV physicians, and we don't have a project in Africa. Mm-hmm. And we went to Kenya, and we went into the Rift Valley, almost as far away as you can get from Nairobi. And we elected to work with the public hospital, which is a challenge. It's not like as if you went in and you planted your tent and you built your own little clinic. So there are challenges working with the public hospital, but the rewards are great, because at the end of the day, you've actually done something to improve the infrastructure. So it's a very different model than going and planting your flag and building your own clinic, and when you're done, you leave and there's nothing left behind.
Yeah. I think this was HealthRight's commitment to building the public health system, not building parallel systems, but right. Strengthening the health system.
Right.
Along with the commitment to these communities. You mentioned going to the Rift Valley so many years ago. I'm proud to say we're still there. Right. We're still in those communities. We've developed really deep, trusting relationships with these communities. We still work very closely with, always in partnership with the government and the public health sector. And we continue to work on critical issues, including HIV, maternal and child health, reproductive health. So, those are a couple of the reasons that I was always deeply impressed with HealthRight, its work. And as important as the sort of mission was also the way the organization went about its work. And I think Jonathan and those of you who were board members subsequently understood the importance of health system strengthening and partnering with the government, because as you say, if you want to have a lasting impact, the government is, in many of these places, is the organization that delivers healthcare. And right. So if we're going to achieve our mission of linking marginalized communities to the public health system, then you've got to work with the public health system, and you've got to solve the problems that have created that sort of dislocation in the first place. Right. And so I really commend you guys for having that forward-thinking vision, and it's something that I think we still honor and implement today. Which brings me to the next issue that I wanted to raise with you. And you mentioned this, you alluded to the fact that the work of the Human Rights Clinic is sadly as important and critical today as it was back when the organization was started. maybe you could reflect a little bit on HealthRight's mission. We talked a little bit about the way the organization has evolved and that shift from sort of humanitarian service delivery focus to a health system strengthening, sort of a longer term sustainable approach to development. Reflect on HealthRight's mission and its relevance to the world today as you see it.
Well, it's interesting in thinking about this meeting. I was thinking about COVID and Jonathan. And if we look at COVID in the United States, who has been most impacted are exactly the populations that Jonathan talked about, marginalized populations, people living in nursing homes, people who are frontline workers, people who are frontline workers, take public transportation and live in crowded housing. So what Jonathan taught us in 1990 about the connection between human rights abuses and public health are very much still present today. He also taught us about the importance of diversity in formulating a response. And one of the things I spoke to my 6-year-old niece about recently was, because she has said she wants to be president of the United States, I told her that in countries headed by women, the COVID response has been better than otherwise. And all the data is not in, but a couple of articles I've read have suggested that women leaders in New Zealand and Germany and Iceland and Finland and Norway and Taiwan appear to be more able to engage a diversity of people in formulating a response to the epidemic, to the pandemic. And we have not done that in the United States. And one of the examples is the 3 sort of pop-up hospitals at the Javits Center, the so-called Comfort Ship, and then the Billie Jean Hospital in where the US Open is held. And the US Open Hospital treated something like 78 patients at a cost of $52 million. And and the Comfort Ship, I haven't seen the data, but it's got to be something like that, and the Javits as well. And I wonder who formulated the response in those hospitals, because when I talk to physicians who are working on the front lines in New York City, or worked on the front lines, they had a lot of ideas about how those systems were set up and why they failed. And if they were not engaged from the get-go, you don't get a good response. And I think those 3 pop-up hospitals were very expensive and failures. What did we learn in the beginning of the AIDS epidemic? Initially, the public health types came out and said, oh, HIV, when we found out it was sexually transmitted, said no more sex. The individuals who, particularly in the gay community, said, that's not going to work. That's not realistic. And they needed to be heard. And as a result of their engagement, formulated this whole idea of safe sex, which meant that people could live with the epidemic and survive with a realistic approach. And, you know, Tony Fauci, in the very beginning of the AIDS epidemic, after a certain amount of pressure from ACT UP, put HIV-infected activists on review committees at the NIH. That was unheard of. That never existed. And as a result of that, they got a better product. And so here we are with COVID, and it feels like so many of those lessons we haven't learned.
And it's funny because these are also fundamental lessons that we know from development work, right? Best practice in development, when you're working with a community needs to be, whatever the community is, they need to be involved at every step of the process, from design to implementation to evaluation, the iterative process of learning from. And we know that you get a better result when you've engaged effective communities, the communities that who you're trying to reach and to address the challenges that they're facing. They've got to have a central role. We work that way at HealthRight. As I said, we always work with governments, local NGOs. The communities that we serve are always at the center of the interventions and the solutions that we design. And that's because we know the product will be better, the outcomes will be better, the impact will be more durable, it will be more sustainable, all of those things.
Right.
So I think it's a critical lesson, and I'm actually glad that you referenced the HIV epidemic, because I do think that there are lots of relevant lessons, and that's a critical one that you just pointed out.
Well, it's sort of interesting because I think people often think, well, you embark on a campaign of diversity because it's politically correct. Well, the reality is that whatever you're dealing with, you get better outcomes by having diverse opinions involved in either, building a pop-up hospital or creating an AIDS program or COVID outreach. Yeah. And we keep having to repeat that lesson over and over again.
Yeah, it reminds me of that phrase that I think came out of the Denver principles, which were driven by the early AIDS activists. Nothing about us without us.
Exactly. Yeah. Yes.
Well,
and language
Vicki,
is important. Language is important. So Michael Callan was involved in that and said, "We are not victims." And as an HIV doc in the 80s, there were lots of lessons that we had to learn, and we learned from our patients. We didn't know how to do a sexual history in 1983. I mean, right. we had to learn that, and we only learned that by virtue of our engagement with patients.
Yeah. Well, Vicki, thanks so much for sharing your thoughts with us today, and for joining us as we celebrate 30 years of HealthRight.
It's hard to believe.
Thank you for your decades of service.
Sure.
I'm grateful. We're all grateful. And
thank you, Peter.
See
you in September.
I will see you in September.
Right.
Take care. Thanks.
Take care. Bye-bye.
Bye.